Welcome to the National Pancreas Foundation's virtual 2021 virtual education series. We'll give it just a few minutes for everyone to join and we'll get started shortly. Good evening and welcome to the National Pancreas Foundation's 2021 virtual education series. I'm Tricia O'Neill, the National Director of Chapter Development for the National Pancreas Foundation. The National Pancreas Foundation provides hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research and advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. Some of our featured programs include the Animated Pancreas Patient, state chapters that support education, fundraising, and patient support, and our physician programs that include research grants, medical education, and our annual Fellow Symposium. Our success depends on the support of many individuals and organizations, and you can make a difference by joining NPF as a volunteer, making a donation, or sharing your own personal story. So thank you for joining us this evening. Tonight, in conjunction with the University of Minnesota's Masonic Children's Hospital, we will host our second session of Pediatric Tpiat education series, Empowering Families and Young Patients with Pancreatitis. Tonight's session will cover nutrition, exocrine insufficiency, and diabetes after pediatric Tpiat. And joining us, we have Dr. Elissa Downs and Dr. Melena Bellin. Please use the Q&A section of the webinar this evening for your questions, and we will answer those at the end of the session. To start us off this evening, we have Dr. Elissa Downs. She's an assistant professor in pediatric gastroenterology, hepatology, and nutrition at the University of Minnesota. She has special interests in pancreatic disease caused by cystic fibrosis and pancreatitis and nutrition, and she holds a master's of public health in nutrition. Dr. Melena Bellin is a physician scientist, tenured associate professor in the Department of Pediatrics, Division of Endocrinology, and the Department of Surgery at the University of Minnesota. She also serves on the National Pancreas Foundation Board of Directors. So with that, I'll turn it over to you, ladies, and thank you so much for helping us tonight.
Thank you, Trish. Yes, I know on behalf of Dr. Bellin and myself, we are honored to be a part of this virtual education series and hope that the session provided will give you guys a lot of information about the Tpiat procedure and how to move forward if it's something that you think you'd be a candidate for. So I'm going to go ahead and share my screen here. All right, and we'll start presentation. So I am going to be discussing some nutrition and kind of GI symptoms, in particular exocrine insufficiency that develops after Tpiat. Please use the chat function to pop in questions anytime, and then I think we'll have some time at the end to work through some of those. All right, so first kind of highlighting nutrition management. I think a key feature of the procedure that ends up happening is GJ feeding tube placement. And I put an example of a feeding tube that we commonly use there on the right. And one of the reasons that this needs to occur is that as a sort of a temporary side effect of the procedure, we end up having gastroparesis, or just delays in stomach emptying. Now, the good news is that this usually resolves within the first month or two after the surgery itself. But in the meantime, we use the G-tube port to kind of drain stomach secretions that might be moving more slowly and causing some nausea. And then we use that J-tube portion, which goes down into the intestines to make sure we're getting excellent nutrition and developing or administering medications that are critical during this time period. Now, usually for most of our patients, in about 2 to 3 months after the surgery itself, that GJ tube can be removed. And that's either something that happens here in Minnesota before you go back home, or something that can be done at your home institution. We end up starting nutrition quite early, about the second day after the surgery itself, and we kind of start dripping some formula into the intestines. And in the meantime, we're using a partially broken down formula because it's better tolerated and we see better absorption with it. And then I'll talk about this lipase enzyme cartridge that we use with our tube feeds to really help with the digestion. As the gastroparesis improves kind of over those first few weeks, people are more interested in eating, and we definitely want you to start eating. So we start with slow portions, small volumes, and then work our way up. And as we're kind of working through introducing some nutrition, we talk very carefully about how we cover those with pancreatic enzymes and how we cover those with insulin. As we start to introduce foods, we keep people on a low oxalate diet. Biggest things might be things like rhubarb or chocolates that have higher oxalate content. And that's just to help prevent kidney stones. If we're not absorbing fat quite as well, we can get some more free oxalate, and that can lead to kidney stones. All right. Things that we have documented over time in terms of nutrition is that we can see growth improving even in those kind of 1 to 2 years after TPIAT, where we're seeing definite improvements in height and weight and BMI. So that's really exciting, coming from a place of sometimes chronic malnutrition related to pancreatic insufficiency before we get to a TPIAT. So during the surgery itself, and I hope that some of you have been able to attend the session 2 weeks ago, where Dr. Shinakola kind of talked more in depth about the surgical procedure itself. But the biggest part of the surgery is taking out the pancreas in total. And you can kind of see from the schematic down here in the right corner, just a brief outline of the anatomy. But as we're taking out the pancreas, we're able to sort of save, with our technology that we have right now, those the islets that can produce our insulin for us. But the rest of the pancreas, that digestive portion of the pancreas, which we call the exocrine pancreas, largely gets trashed, unfortunately. I'd love that someday we have the technology to be able to save this portion, but right now we don't. So afterwards, because we've lost these different enzymes, so the amylase and the protease and the lipase that helps us digest carbs, proteins, and fats, we need to supplement you for the rest of your life with these pancreatic enzymes. So with every meal and snack, making sure that we're covering it with the enzymes to help us really complete the digestion and absorption. And then because we're not going to be perfect, there's always going to be a little bit of mismatch. We do know that there might be a potential for vitamins to be malabsorbed, and in particular, vitamins A, D, E, and K, which are fat-based vitamins. And so lifelong vitamin supplementation and kind of lifelong vitamin monitoring to make sure we're dosing those appropriately. Pancreatic enzymes come in a few different forms, so we're pretty lucky from that standpoint. The first form, which is a relatively newer medical device, is called Relizorb. And this is a cartridge that contains just lipase only. So it's one that helps us just digest the fat in formula. But it hooks in line with the tube feeds, digests the fat, and then the digested fat in the formula flows into our body. We can get really good efficacy with this, even though it only contains the lipase enzyme itself. When we're moving on to eating and drinking and covering our intake by mouth with enzymes, you can see we have a variety of different ones to choose from. Most often we're using Creon, but there are a few other different brands. You can kind of see they come in different capsule strengths in different sizes. So sometimes we're doing higher number, but the lower dose of the enzymes themselves. Each enzyme manufacturer has a slightly different technology. So you can sort of see they come from like micro beads to micro tablets, but they all work about the same way. As we think about dosing, this is something that is sometimes a work in progress, because there are a few different methods to help us address the proper dosing. So I touched on this briefly. When we're doing continuous tube feeds, we can do the enzyme or the lipase only cartridge. Most often, once we're getting to our goal nutrition, we're changing this cartridge just twice a day. It just sort of screws in line with the tube feeds themselves. And so pretty straightforward from there. And then as we're starting to eat and drink, we're adjusting our enzymes in two different ways. So either we're looking in general at your weight or your body size, and trying to figure out, okay, what is the right amount for you that you need at a time. So sometimes we're starting somewhere in the middle and adjusting kind of upwards or downwards as we need. So it's a fairly broad range of enzymes that we can use. If people are a little bit more scientific or analytical and they know exactly the fat content of the meal that they're maybe going to be eating, we can choose a different route to dose the enzymes and really looking at it from more of the grams of fat that you're doing per meal. So that one's where it might be a slightly different amount for each meal, rather than sometimes we're saying, 4 per meal and 2 per snack in general. We have sort of a ceiling limit that we don't want people to go over, and that's 10,000 lipase units per kilo per day. In the past, there were some side effects when people did more than this. So we just want to kind of cap it overall. Really important that we're taking this before every meal and snack. Now, there are some times where if we're eating really simple carbohydrates like straight juice or, really kind of simple piece of candy, we may not need enzymes, but most everything is going to be complex enough that we really want you to get in the habit of doing enzymes before every meal and snack. We talked a little bit about the importance of pancreatic vitamins. We have a few different kinds that we commonly use, but I showed you just one example of that, the MVW brand. And these have significant overlap with cystic fibrosis and the needs for people that have cystic fibrosis and exocrine pancreatic insufficiency because of that. And so we kind of follow guidelines for patients with cystic fibrosis in terms of how we do these dosings. So on the right-hand side, you can just see a few columns of the different types of vitamins and how much of our kind of vitamin A, D, E, and K needs that they need. I will lump in GI management and some kind of complications of the procedure sort of together as we're moving forward through the next section. And trying to break it down first in sort of the time frame that we think about this happening. So in the immediate kind of post-op and recovery period, a few things that do occur. We talked a little bit about gastroparesis or delayed stomach emptying. And then overall, just dysmotility or slow motility of the intestines because of the surgery directly on them, because of pain medications, because of blood sugar, because of all those other types of things that we'll get into more detail about. Nausea is a big one from either pain, from just recovering from the surgery, again, from slow moving intestines or from kind of some of the medications that we're using. Achilles leak is a surgical complication. We won't really talk about it much during this presentation, but it's one that we see happen in a small number of patients, and we just institute a really low fat diet and let that heal. And usually about 6 to 8 weeks later, we're expanding the diet again and we can move on without any really long-term complications. As we look in sort of the months to years timeframe after the surgery, we can sometimes see some issues with bacterial overgrowth, and I'll talk about that just a little bit more. And then really anytime we can see things like constipation, kidney stones, which I talked about previously, things like stomach and intestinal ulcers, malabsorption, causing stomach pain, causing diarrhea, bloating, greasy stools, and then potentially leading to vitamin and mineral deficiencies if we're having issues with absorption. So we'll go through a few of those coming up here. All right, so we talked about gastroparesis or dysmotility being more of a temporary side effect of the procedure that we get through over time. So we're draining the stomach, and then we're also usually using at least one medication to really help move the stomach and move the intestines along to help with recovery. Those are usually antibiotic-based medicines, but we don't necessarily see any issues because they are antibiotics. We're using them for their side effects in this case. Now, most often, like I said, temporary side effects, but in some patients, this can be prolonged. So we may need to do a longer duration of tube feeds. We might be doing some kind of partial tube feeds, partial oral intake. We may have you try and do other dietary changes, so things like lower fat or lower fiber diets, which are going to move through the intestines more quickly. And then we may use these motility agents more chronically to try and help keep things moving through. Now, there are a few research studies that have been published on kind of delayed gastric emptying that may occur and kind of more chronic dysmotility, but it's not something that has been quantified a whole lot as we're looking at patients after TPIAT. So it's certainly something where we expect some early dysmotility to happen, but for the most part, patients are usually recovering from it without issue. Nausea is a big one. If any of you have gone through surgery before, you know that there's lots of complicating factors that lead to more nausea as we're recovering. So we talked about intestinal motility issues, pain, the different medications that we're using, constipation, anesthesia, things like that. So we try to hit this from any number of different angles. So we're using some of those medicines for nausea. We're using some of those medications that are going to help move the stomach and intestines along. We're really aggressively treating constipation. We're looking for overgrowth and kind of trying to recognize if it's there so that we can manage it appropriately. And then also looking at how you're doing with your enzymes and if we need to make any adjustments to the timing, the dosing, anything like that. Lots of non-medication therapies are used to help with this as well. So early on, if your G-tube is still in place, we're going to use it to vent or drain stomach secretions. We get our integrative medicine practitioners involved as well. We may do things like aromatherapy, acupressure, C-bands, fans. So we have lots of different non-medication ways to help with this as well. But good news is this gets better over time within those first month or two. All right, so I talked a little bit about bacterial overgrowth being a potential complication. So I'm going to get into more of that just a little bit here. So what that ends up being is when we get more of that population of bacteria that live in our colon that kind of are migrating into our small intestine and then kind of overgrowing in abundance. And so this is just a little picture of that where on the top, we can see what the normal population looks like. So in the small intestine here, where it's pink, we have a lower number of bacterial population. And as it gets into more of this sort of like pinky gray color and then green, those numbers rapidly rise. So kind of rising in numbers as we head further down into our intestine. But what can happen with overgrowth is that now those bigger numbers and those bacteria that live in our colon kind of migrate upwards. And the problem there is that they are working on kind of the leftover nutrients from our food, and they're breaking them down more, which is causing a lot of gas, a lot of fluid shifting, and it can make us feel really uncomfortable. The risk factors for someone to develop bacterial overgrowth are people that have had any surgery to their intestines, and then anyone that's experiencing kind of motility changes, which we've kind of addressed in terms of different medications, especially pain medications. Can be happening from diabetes and from a number of other issues. Malabsorption can be a risk factor as well. So if our body is not breaking down and absorbing all the nutrients in our food, we're just leaving more behind for our gut bacteria to process and to make and produce more gas. Antacid therapy is also a risk factor. So how do we manage this? We try and recognize who's going to be most at risk, which is unfortunately our population that has undergone TPIAT. But are they patients that are maybe needing more chronic pain management? And can we kind of tweak the routine and use medications that don't slow down the gut as much? Things like that. We sometimes think about doing a course of antibiotics, which is really just to take the population and knock it down so that it's not causing quite as many problems. And then possible or unclear benefit that people have looked into over time would be a low FODMAP diet, which are just foods that as they digest produce less gas overall to see if that can help make us feel better. And then probiotics haven't necessarily been proven to be helpful over time, even though intuitively it seems like they should be. But those are sometimes things that we do track. Now, the good news is that if we recognize this and we treat it, we can make it go away. There's always a possibility that it can come back again over time, especially if we have not modified the underlying risk factors. Constipation. As a GI doctor, I spend a lot of my life talking to people about constipation, but just so you know, this is very common afterwards. It certainly can occur anytime, but that highest risk does seem to be in the immediate post-op period when we're relying on more opioid pain medications, when our intestines are healing after surgery, things like that, especially when we're not up and moving and active. So we manage this in a number of different ways. We're pretty aggressive with things like Miralax and other softeners. We use a lot of stimulants to really help the intestines push and squeeze the poop through, and then we modify our pain management if we need to. And then non-medication management is really just making sure we can get you up and moving around, really looking at your fiber intake, really looking at your fluid intake, and seeing what tweaks we can make there. In the bottom right corner, I put in a Bristol's tool chart. This is not the one we most commonly use, but I thought this one was kind of cute. We do tend to ask you about your poops pretty much anytime we're talking to you. So this is something that you will see many, many times if you haven't already. All right. Malabsorption is unfortunately something we know is going to occur. Like I alluded to before, we are never going to be perfect in matching the enzymes you take by mouth to what your pancreas at its best function was doing before. But a few additional factors that can play into this would be if we're not taking or storing our enzymes, if we do have bacterial overgrowth, or if there's other intestinal inflammation that's causing some problems. When we're malabsorbing, we're getting a lot of cramping, bloating, gas, and pain. So it's uncomfortable and we want to make sure we're addressing this. It also leads to vitamin deficiency. So if we're not absorbing our fat well, we're not absorbing those fat-based vitamins well. And this was something that we had looked at our center and found that vitamin deficiency was pretty common. And so we need to be wary of it and treat it appropriately. So we talk about how you're doing with taking your pancreatic enzymes. You may adjust the enzyme dosing. Sometimes we add in antacid medications to make those enzymes work better, or we're thinking about other GI workup to pursue. All right, so back to my summary here for you. Now, as we're looking at things, everyone gets a feeding tube. We're using formula feeds early on to help optimize nutrition. But as things like nausea and the gastroparesis improve, we can wean off those tube feeds and let you eat and drink. And then that tube feed feeding tube, is coming out about 2 to 3 months later. Because we cannot save the digested portion of the pancreas, we're needing those pancreatic enzymes lifelong. And then we also need lifelong vitamin supplementation. Constipation is common. We're pretty aggressive in managing it. Less common are going to be things like chylous leak or that bacterial overgrowth or ulcers or kidney stones, but we're always kind of on the lookout for those. And then we do see better growth after TPIAT, which is really exciting for people, especially that may have been not growing so well beforehand. All right, so thank you there. My email is up there. You don't get a chance to get questions answered today, and then I will pass it off to Dr. Bellin to talk about diabetes management.
Thank you. Thank you, Elissa. That was really wonderful. I'm really going to talk about the other side of the pancreas spectrum, and that is diabetes, and particularly diabetes and diabetes management after TPIAT. So I'm actually going to start at the beginning. I know some people on this call or this presentation have had a TPIAT. They're very familiar with islets. But I think until you get to the TPIAT stage, oftentimes islets aren't really a part of the pancreas you talk much about or think about. So I'm really going to start with what is an islet? What does that mean? Talk about the islet auto transplant portion of the procedure. Dr. Chinakotla really went through the surgery in detail in the session we had previously a couple weeks ago. So I'm not going to talk much about the pancreatectomy part, but really specifically about the islet auto transplant part and the outcomes that we see after islet auto transplant, anything from being all the way off insulin after a few months to having to use insulin lifelong. And then really from there, get into the more practical aspects of diabetes management after TPIAT. And what steps, albeit limited, what steps you might take as a patient to optimize long-term islet function. So now when we see patients, particularly children for pancreatitis, the main concern is obviously pain, hospitalizations, and pancreatitis interfering with quality of life. But as pancreatitis continues, even in the absence of surgical treatment like TPIAT, the pancreas itself becomes scarred. About 2%, so a very small portion of that pancreas, is the islet tissue, the islets being the cells that make insulin and prevent you from having diabetes. The other 98% is the digestive portion of the pancreas that Dr. Downs talked about. And if we look at children with chronic pancreatitis, although it's not as common as in adults, certainly about 6 to 8% of children with chronic pancreatitis or recurrent acute pancreatitis will in fact develop diabetes in childhood. And as disease progresses and scarring progresses, more of those islets are lost and the risk for diabetes goes up lifelong. So individuals with hereditary pancreatitis starting in childhood, that risk of lifelong diabetes, even though it might not happen until 40 or 50 years of age, is about 2 out of 3 patients with chronic pancreatitis. So what exactly is the islet? First point of clarification is that it can be a tricky word to pronounce, and it's spelled kind of like islet, but it actually is pronounced islet. And we oftentimes will say islet cell. Well, that's not quite accurate because an islet is really a cluster of many cells. So on average, an islet will have about 1,000 cells, and the main cell types in the islet are the beta cells and the alpha cells. The beta cells make the insulin. So the insulin's the hormone that allows our muscles and our fat cells to utilize the glucose, the sugar that's in our blood. So it helps regulate blood sugar, and you need to be able to produce insulin. If you can't, you have diabetes. Alpha cells make a hormone called glucagon. Glucagon is important if your blood sugar gets too low. It's one of the several hormones we have to raise blood sugar back up into a normal range. And there's a couple other cell types that are perhaps less important clinically. There's a cell called PP cells that produce pancreatic polypeptide that might play some role in the development of diabetes and chronic pancreatitis, and delta cells that produce a local regulatory hormone called somatostatin that helps regulate the insulin secretion in the islet. Some islets are small, some are large. So small islets might only have a few hundred cells. Large islets might have several thousand cells. And when you hear doctors talk about islet mass or how many islets that were transplanted, you'll oftentimes hear this term called islet equivalence, or it's abbreviated either IEQ or IE. And that term islet equivalence is basically taking into account that some islets are small and some islets are large, and are standardizing the number of islets to the size of a medium islet. So it's accounting for that islet size variability in the islet count. Islets get a lot of blood flow. So they're what we would call highly vascularized. Islets are only 2% of the pancreas, but they get about 40% of the arterial blood flow from the pancreas. So those cells, those beta cells that produce insulin, need a really good supply of oxygen and nutrients to function. And the reason that's important in islet transplant is when we do the islet isolation, we actually remove all of those small vessels, and they have to reform in the new place that the islets go, typically in the liver. And islets are scattered throughout that digestive or exocrine portion of the pancreas. So they're not easy to isolate because they're really interwoven within the rest of that digestive pancreas and connected to that digestive pancreas by fibers like collagen. So these pictures that I have up here are really just illustrating, they're pictures of actual islets. The top one up here is from a group that does some research in vascularization and shows these green areas are the blood vessels that come into the islets and supply all the cells of the islets. And then the lower image here is actually staining of the different types of cells. So the beta cells and the alpha cells are the blue and green ones in here. So what about the islet autotransplant procedure and the outcomes we see from that? So I do always think of TPIAT as actually two different procedures that are done in one surgery. So there's the pancreatectomy part, and that's really the very important part of the surgery, right? That's the part that is designed to relieve the pain, eliminate those episodes of acute pancreatitis, allow a better quality of life. So one could go and just do a pancreatectomy, but if you did the pancreatectomy without the second part, the islet autotransplant, you would essentially be throwing all those islets out, and you'd have a surgical form of type 1 or juvenile diabetes where you're fully dependent on insulin. So the goal of the islet autotransplant is really to rescue back as many of those islets as we can, put them back into the patient's body, again, the most common place being infusing them into the liver, and hoping that as many of those islets take up their home there as possible, so that we can either entirely reverse the diabetes of pancreatectomy, so have people come off insulin, or at least minimize the severity of that diabetes so that it's easier to manage. Most of our patients who are going into a TPIAT procedure do not have diabetes before they have their TPIAT. That's particularly true for children, but not always the case for adults. And so about 8 to 10% of the time we see patients who do already have diabetes from their pancreatitis before they have this surgery. And those individuals are going to continue to have diabetes after surgery. It's not that the islet autotransplant is going to reverse the diabetes in that case, but it's still the goal is to keep that diabetes easier to manage. So what happens in islet isolation? So that's kind of the magical part of this procedure. We don't put the pancreas in a magic hat, but sometimes it feels like that. You have this formed organ of the pancreas. You put it through this digestion process. So the islet isolation team picks it up, takes it to the islet isolation lab for a few hours, and voila, they have a islet product that they bring back into the operating room for the surgeon to infuse in the liver. Well, the way that process works behind the scenes is that there are always two basic steps to that islet extraction procedure, or that pancreas processing procedure, and sometimes a third. So the two steps that are always involved, the first step is to take that pancreas. Now, this is actually up in the upper left-hand corner here, a pancreas from a deceased donor for a transplant for type 1 diabetes. So it looks considerably healthier than what we might see from a scarred pancreas with chronic pancreatitis, but the concept is the same. The lab will actually put in a catheter into the pancreatic duct. And under a lot of pressure, they'll infuse a enzyme solution that has something called collagenase. So collagenase basically digests collagen. Collagen is that fiber that holds the islets to the digestive tissue, the digestive part of the pancreas. So it basically loosens up the connections between that digestive part of the pancreas that we want to get rid of, and that's causing the pancreatitis, and the islet cells. So once that process is complete, then it goes into this special chamber. It's called a Ricordi chamber, illustrated down in the bottom left and the kind of middle upper area here. It essentially will shake the pancreas back and forth, and now these connections that hold the organ together are gone. So the pancreas becomes more of a liquid slurry form of pancreas. And the islets can be filtered out from that. The islets are small, so they're smaller than these chunks of exocrine tissue. And they go through a filter system and collect this digest, which is, in here, there's staining. So you can see the islets. So islets stained in red. And then this kind of gray tissue on this lower pane in the middle is some exocrine tissue that surrounds the islets. We need the amount of tissue that we have for transplant to be small enough that we can safely infuse it into the liver. So sometimes if there's a lot of kind of exocrine digestive tissue coming along with the islet product, about 10 to 15% of the time at our center, we'll do this extra step called purification. It basically spins down the islets and the exocrine tissue to kind of separate out the islets that aren't as dense from the exocrine tissue. The problem is you'll lose some islets along the way. So we only really do this if we need to. When this islet tissue with the exocrine contamination is infused into the liver, only the islets survive. The rest of it just gets washed away and dies off. Only the islets stay in the liver and survive that transplant process. So the main reason to get it more pure is just to make sure we can fit everything in the liver. This is, although this sounds kind of standard, there's step 1, step 2, and maybe step 3, there's actually a lot of individualization to each pancreas. So the age of the patient, kids are a little bit different than adults. The amount of scar tissue that is throughout the pancreas can really affect how our islet team approaches, especially that first step of digestion, and to some extent the amount of time that the pancreas is in that second step, to make sure that we fully digest away all that scar tissue that can be kind of tricky to digest. So then what happens to the islet? We put it into the liver, so it gets infused into the portal vein. The portal vein is a vein that flows towards your liver. So the islets just follow with the portal vein blood flow into the liver. That branches off into these really tiny vessels called sinusoids, and the islets just get stuck in the liver. But obviously this process of extracting the islets is not natural. So there's a lot of stress placed on the islets just by the extraction itself. And then you put these islets into the bloodstream, a place they're not usually right in the bloodstream. So you generate this inflammatory reaction. The body sees this tissue in the bloodstream and it kind of acts as if you got a cut. It sees something that's not supposed to be there, and it creates inflammation and tries to create clotting around the islets, which is why we give medications like heparin and dextran. Like I said, those blood vessels, those tiny little blood vessels that bring oxygen to the islets are all removed. So initially they're what we would call devascularized, and they have hypoxia, meaning very low oxygen conditions. So that's why they can't function very well initially, because they really need a good oxygen supply to make insulin normally. They also actually have nerves in the pancreas that go to islets. Those never, I think, reform. We think they don't functionally reform in the liver, so they do remain without that innervation, but they do seem to work despite that. And so all of these things, this isolation stress and low oxygen levels and inflammation, all of that can lead to something we call beta cell apoptosis, or loss of islets. So we know that everyone who has this TPIAT procedure, some of the islets aren't going to survive the transplant process. One of the things we know is helpful in allowing more of them to survive is to keep the blood sugars really well controlled, so that we're not putting a lot more stress on them to try to make insulin when they have this inflammation surrounding them and they're not getting good oxygen supply. So that's why we have this concept of islet rest right after TPIAT, where we're giving everyone insulin therapy. So we give everyone insulin therapy for at least a few months after the surgery. And even people who come off insulin are usually on for about 6 to 12 months. We really let those islets heal. And then over time, if we're able to, we gradually remove insulin therapy. And what we've really seen historically in our program, and I think it makes logical sense, the more islets you get in the first place, the more likely statistically it is that you're going to be able to wean off insulin. And so we would consider someone getting what we would call more than 5,000 islet equivalents per kilogram body weight, or IEQ per kilo. We consider that to be a high number of islets for someone who has chronic pancreatitis. And if we can get that many, then the insulin independence rates are pretty good. They're more than 50%, up to about 2/3 of folks. But we get more kind of in between levels of insulin independence if we have fewer islets than that. So we know how many we start with matters in addition to how many actually survive that transplant process. Age does make a difference. If we look at kids versus adults and how, and this is just data from our institution as of a few years ago, that's not published in these particular graphics, but if we look at our population, about 30%, 25 to 30% of adults are off insulin, but it's closer to 40 to 50% in children. But in fact, if you tease apart that kids data, the higher rates of insulin independence in kids are largely not teenagers. Teenagers do pretty similar to adults. It's these young kids that are age about 3 to 10 or so. Somewhere around age 9 to 11, we start to have less success with the islet auto transplant, at least in terms of insulin independence. But these younger kids are coming off insulin 50% of the time, or even more often in the younger age group. So there is a factor of age here that's important. One thing that I'm sure probably many of these people on the who are listening today have heard about is not having surgeries before the TPIAT procedure. So, we're really just focused in this particular webinar series on TPIAT, and that's not because TPIAT is the only choice for everyone. It's typically the choice for children with genetic disease, but there are other surgeries that are sometimes done in adults and much more rarely in kids to open up an obstructed duct or remove part of the pancreas. The challenge is that those procedures oftentimes don't work very well for genetic disease. And if you do a different surgery that involves opening up the pancreas duct, and I'm talking surgically, not with the ERCP, but surgically opening up the pancreas duct like a Fryer-Pusteau, or taking half the pancreas out, and then you still need TPIAT because you're in pain, the number of islets we get is much, much lower. And that's partly because these surgeries make it more difficult to do the islet isolation process, and partly because people have, by that point, have had disease longer, so they have more scarring and fewer islets left there to get. So a really common question that I get that I don't have the best answer for is, when is the right time to do this for diabetes? Obviously, TPIAT is a really big surgery. And as you heard a couple of weeks ago from Dr. Downs today, there's a lot of medical complications that can occur after a TPIAT surgery. So we don't want to take someone to TPIAT surgery who doesn't need it, who maybe can manage through more mild disease medically. But on the other hand, if someone's going to go to TPIAT, in terms of getting enough islets, sooner is better. But I think what our data says is it's probably not an emergency to rush to TPIAT. We don't have a way to count islets exactly or image islets exactly in the native pancreas when it's in someone's body. We can only really precisely count the islets when they come out. There's some tests we can use that are helpful, but they don't precisely count islets. So if we look at PRSS1 disease, so a really common form of autosomal dominant hereditary pancreatitis, and we look specifically at different patients who have hereditary pancreatitis due to PRSS1, but kind of have a similar course. The disease usually starts in childhood. We know that if they get to be adults more than 21 years old, that it's very uncommon to come off insulin independence, or to come off insulin and get insulin independent. It's not unheard of, but it's very, very rare. If we actually look at the number of islets that are there and what that progression looks like over time, statistically, it looks like if you wait about 5 years for TPIAT, for about every 5 years of disease, at least with PRSS1, your islet mass goes down by about 20 to 25%. So it's not necessarily a lot in 6 months or a year. So there is some room to wait, but certainly we're losing islets at, 5 years or 10 years down the road. So what does the future hold? Is most of what I talked about in this presentation for outcomes was a few years, within a year or two after TPIAT. What about longer? Well, we know that people who come off insulin, and just to give you what this graphic says here, on the left here, this is actually pain symptoms. So pain resolution is actually relatively consistent statistically. Patients report improvement in pain at about the same percentage, and this is both peds and adults through 10 years. What happens with islet graft function is the proportion who are insulin independent, who have full islet graft function, does decrease over time. That's these white bars here, and fewer patients have islet function over time. What I typically like to tell people who are coming in for a TPIAT consult, especially if they're young, is that we can get, in some cases, 5 or 10 years, or even longer in some cases, of insulin independence. But our current knowledge would say that we don't expect that these islets are going to last forever. And when someone is off insulin, that we expect at some point in time, they'll eventually have to return to using some insulin. That doesn't mean that their islets have totally failed. They may just return to using a once a day long acting insulin or very low insulin doses. But at some point in time, we're going to have to help those cells out again by restarting some insulin. We do have some kids who are in that 10 to even beyond 15 years out off insulin from their surgery. We have an adult patient who is 21 years out off insulin. So we do have a few cases of very, very long islet function. So what are the practical management aspects of diabetes to think about after TPIAT? Well, I kind of had referenced before that we really want to let these islets rest, so we're not putting them under too much stress. So we do early on after surgery pretty aggressive insulin management, and we do that by, for a few days after surgery, the first week or so, putting the insulin straight into the IV and doing an insulin drip. And then we switch to subcutaneous insulin therapy, meaning under the skin, that I'll talk about, either by injections or pump. And essentially sometimes, and this actually comes usually more from providers than patients, but people will ask, well, how much difference does it really make in terms of islet stress? If you're talking about, 20 points or 40 points in the glucose. But we have some studies, some of our closed loop pump studies, where we've measured glucose and C-peptide in the first week after surgery. That's this left graphic. And what we do really see is that even small changes from 90 to 150 in the glucose, so not extreme hyperglycemia, but mild hyperglycemia, are putting a lot more strain on those islets to secrete more C-peptide. That's our marker of insulin production. So on a positive note, these islets are actually functional and doing a little bit early on, but we don't necessarily want to be pushing up the blood glucose to 150 or 170, where we're asking them to do a lot. We also do see, and it's hard to say what comes first, the chicken or egg, but if we look at average glucose control in the first week after surgery and people who come off insulin or don't come off insulin, we see about a 10-point lower average glucose in the first week after surgery in those patients who eventually do come off insulin. And this ends up being even more so true if you're talking about people who have low islet mass. So we do, I think, have some evidence in people that that being aggressive and really targeting normal glucoses does help reduce strain on the islets and may help with long-term insulin independence. So what ways do we give insulin and monitor blood sugars after we switch off that insulin drip? So there's really two ways to give subcutaneous insulin, and the way that is still just fine and works is to use insulin pens, but we don't do that so often in our pediatric population anymore. Insulin pens are nice and user-friendly. They work. You have long-acting insulin and short-acting insulin and insulin pens. But they are a little bit limited in the dosing. They go in half unit or 1 unit increments for dosing. So you can't be as precise in smaller people and children with insulin pen devices to give separate shots for everything. So more recently, what we do is do an insulin pump. We have one particular brand that we tend to use here for the TPIT population for various reasons, but there's multiple pump brands and they're all just fine, and they do kind of the same thing. And what an insulin pump does is puts a little catheter under the skin for subcutaneous insulin that the patient changes out every 3 days. And in between those every 3 days, all the insulin just goes through that machine, and you don't need to do a separate poke. And the really nice thing about insulin pumps for us as a medical team is you can be very precise about how much insulin you're giving. So you can give someone a 0.1 unit dose of insulin. You can't do that with a pen where you're limited to 0.5 or 1 unit of insulin. So we like the precision of that. And if there's an emergency situation, a really low glucose, the tube feedings that Dr. Downs was talking about get interrupted, we have the ability to turn off that insulin from the pump. And it's much harder to do that if you're on an insulin shot. You can't take away the insulin that's already under the skin with a long-acting insulin. So we've really moved towards doing a straight conversion from the insulin drip to the insulin pump therapy in hospital now in the children. And I think from a patient perspective, I think patients generally tend to favor that too, because they're not needing to worry about the injection part. For monitoring, we still use finger pokes and meters an awful lot for monitoring. They're the most accurate way to do monitoring right after surgery. But we have a lot of use, even early after surgery, but especially long-term, of some of the continuous glucose monitors, which are sort of these devices here on the left side of both abdomens, a couple of different brands. The continuous glucose monitors also have a filament that sits under the skin and measures something called the interstitial glucose, or glucose that's outside of your bloodstream between the cells, about every 5 minutes, and it's pretty close to blood glucose. The biggest issues we have with sensors early on is some of the medications we give for TPIT, and some of the fluid shifts that can come with surgery, like dehydration or even edema, can interfere with how the sensor works. So we still actually need to rely on the finger poke testing a fair amount early after the surgery, but by several weeks or a couple months after the surgery, we can start to rely on the sensors more and more. So the modern management of TPIT in the hospital and outside the hospital for young patients then looks something like this, where you're wearing a couple devices, and one is your insulin pump that is infusing the insulin. The other is a continuous glucose monitoring sensor. And what's really nice from a provider perspective for management is with the CGM, the continuous glucose monitor, we get this continuous tracing across the day. That's the green line of what's going on with blood sugar. And then because the computer that's the pump stores all the insulin administration data, we can see exactly where all the insulin doses are being given, and we can put that together to really manage diabetes better. So we're always about research, as many of you probably know, here at the University of Minnesota, and always want to study what we're doing as we implement it. So we did look specifically with the most common brand of sensor, the Dexcom G6 sensor, using it early after surgery when people discharged from the hospital. And although there are some challenges with accuracy around certain medications, what we saw on average is patients, children who had access to the traditional Dexcom G6 sensor did have a lower average glucose compared to those individuals who are only using a meter where we just put a blinded sensor on. So we do think these sensor systems, although they take a little bit of a learning curve to figure out exactly how to interpret all of that data, are very helpful after surgery. So although this is a study from 2016 that I'm showing you, I hope that this is the next step in technology. I had a very brilliant colleague of mine, Greg Forlenza, who trained here and is now in the closed loop pump field at Barbara Davis Center, who did this early closed loop pump study in the adult TPIAT population in hospital in 2014, 15, 2016, around that time. We used a very old system that was connected by a laptop computer that had an insulin pump and a sensor and a control algorithm. So essentially, this is what people talk about when they're talking about artificial pancreas technology or closed loop pump technology. They're just talking about the diabetes part of the artificial pancreas, but that the pump is automatically regulating insulin delivery based on a sensor glucose. And we did this for 72 hours in inpatients in the adult setting. And we had our own algorithm developed, particularly for this study, with a very tight parameter on it. And it worked beautifully. So our patients who were on the closed loop pump, which is the blue bars here, all had lower average blood glucoses than patients who, in this case, in the adult setting, were getting insulin pen therapy with multiple daily injections. That's MDI on here, and CL is closed loop pump on this graph. So this is something we'd actually really love to translate to the outpatient setting. We have a number of patients who are far out from their TPIAT who use closed loop pump technology that's available on the market now. Our challenge has been that the targets in the commercial models haven't been set as tightly as we would like to use it in the first few months after surgery while those islets are settling in. But we do believe that some of the systems that will be coming out in the market in the next year or two are going to give us that ability to set a tighter target where we might be able to introduce some of these technologies sooner after TPIAT. So what about you as a patient? Are there, what steps can you take for your islet health and your diabetes health? And I think the most important thing to say here is that there are a lot of things that are not under your control, particularly the number of islets and sometimes how well they engraft. So you could do everything exactly right and still need insulin. However, I think there are a few steps that people can take to be as healthy as possible, both their own health and their islet health. I always tell people, if you are off insulin, do continue to intermittently check glucoses. Most people off insulin will do this with a meter, just because they don't have to do it very often. And once someone gets out a year or more from surgery and they're very stable and they're off insulin, I usually say they can reduce to doing a morning and a bedtime, even as seldom as 3 to 4 days a week if things are going really well and very stable. But I don't recommend stopping monitoring entirely. And sometimes patients will get conflicting information or advice on that from providers who don't manage TPIAT. And it can be tricky because, as I said, some people have islet function and are off insulin for 10 years. So someone who's really stable, it's easy to question, why is it necessary to keep monitoring? Unfortunately, in patients who have stopped monitoring, there are not a lot of symptoms of high blood sugar. And I've seen some of those patients show up in the emergency department with blood glucoses of 400 to 500 that they had no idea, because just don't have enough symptoms to realize that anything had changed. By that point in time, it can be dangerous for your health, but it also you've lost a lot of the islet function we had. So if we can catch very early on that blood sugars are slowly rising and that there's a decline in islet function, we can just start back on 4 or 5 units of long-acting insulin. And oftentimes that's all we need to do. So I think monitoring is really important. Obviously, if you're on insulin, you have to monitor more often than that to adjust insulin therapy. Staying physically active and maintaining a healthy body mass index. This is a pretty common piece of advice to any form of diabetes. The reason for staying physically active and maintaining a healthy body mass index is that people who are active and who have a normal BMI tend to be more responsive to the insulin their body makes, or we call that more insulin sensitive. So they can get by with fewer cells and still stay off insulin because their body doesn't need to make as much insulin. It doesn't put as much stress on the islets that are there. If we look at long-term survival of insulin independence, being overweight negatively impacts the ability to stay off insulin long-term. I always recommend avoiding regular pop and other high sugar beverages. That sugar is absorbed really quickly and puts a lot of metabolic stress on the islets. So that I think is hard on the islets, although I would say we have less concrete data on that. I hesitate to be overly restrictive about diets in growing children, but just do recommend a generally healthy diet. And if you are on insulin or sometimes other diabetes medications, although usually it's insulin, we do recommend to adjust insulin therapy to maintain your glucose target. For most people with islet function, that's maintaining an A1C of 6.5% or less. Some people who have very little islet function, that goal is a little bit too strict. So there is some individualization there. So in conclusion, islet autotransplant is that part of the procedure, that second part of the procedure that is performed to preserve as much islet function as possible, ideally to reverse diabetes or at least minimize it. All patients need to stay on insulin for at least a few months after surgery. That's because we want to rest those islets as they're making their new home in the liver and getting the new vessels and getting healthy. But eventually about 1 in every 3 patients will come off insulin, and that's higher in younger children. And diabetes management can include shots or pumps. Neither is right or wrong, but we do tend to favor pumps in kids and smaller individuals, and meters or sensors for monitoring. This is just an acknowledgement to our team, because although I focused entirely on diabetes, there obviously is a huge team that is necessary for a TPIT procedure at any institution. All right, thank you. I will close this out and I'll come back on camera with Elissa and we could take some questions.
Thank you so much, Dr. Brown and Dr. Bellin, for that great information. We do have a couple of questions. Some of them you may have covered, but we'll just recap it if we need to. One of the questions we will start with is, how do you generally see the gastroparesis and dysmobility last? How long does it last after surgery?
Yeah, great question. And I'm sorry if I wasn't thorough when I was covering it. Usually within probably those first kind of week and a half to 2-3 weeks, we have patients really start feeling good and wanting to eat and drink. And it may even get to the point where we're eating enough that we're able to start backing off on our tube feeds right away. But in general, we kind of see it somewhere between kind of months 1 and 2, kind of rapidly start to get better. There are some patients that kind of linger on for sometimes a few months afterwards, but they are more likely the people that have had issues with slow stomach emptying or slow moving intestines before coming into the surgery even.
Thank you. The next question is, what is the prognosis for a child with chronic pancreatitis? How many children follow a declining pattern of quality of life? For example, if a child has had many hospitalizations in 1 year due to chronic genetic pancreatitis, how many can recover and reduce hospitalizations without a Tpiat?
Well, I can give you my impression, and then Dr. Downs may actually be better at answering this question because she sees more kiddos than I do who aren't coming specifically just for TPIT evaluation. We certainly, even within the TPIT program, will sometimes see patients who have been symptomatic, decide to hold off on TPIT and do seem to improve. However, I think we get pretty concerned if someone has pretty advanced disease where they've had a significant number of hospitalizations, they have strictures, they have stones that are not amenable to just ERCP treatment, that is probably more difficult or less common to reverse.
Thank you.
What do you think, Dr. Downs?
Yeah, if we've kind of gotten to the point where we've already had a few hospitalizations in a year, we don't often see that that's going to get much better. And it is something that, we'll have to continue to manage lifelong. And the key is really if we can work on different medical therapies, potential endoscopic therapies, or other surgical therapies that might be able to give us some time. And certainly there are a lot of people with PRSS1 that don't end up progressing to TPIAT. So it's considered for the instances where we need it, where we're having chronic pain that we can't manage otherwise, but we do have a lot of other options that can help.
Thank you. The next question is, my daughter is being considered for a Tpiat due to her chronic pancreatitis. She's been underweight her entire life. Do patients need to gain weight before a Tpiat?
Yeah, that can be pretty difficult. We definitely want patients to be more of a healthy weight going into the surgery. That can help not only with our recovery, but our overall nutritional management. So there are times where even before the surgery itself, we'll have patients do a trial of tube feeds, or maybe even have a surgically placed G-tube before the tube that would be placed during the TPIAT.
Okay. Dr. Bellin, the next question I believe was for you, and we'll go back to the other one. For Dr. Bellin, is there a direct relationship between A1C and diabetes post-Tpiat, or is it possible to have a lower A1C and still be insulin dependent?
Yes. So Paul, I'm not sure if you mean the A1C before the TPIAT or after the TPIAT procedure, but it is possible. And in fact, it's not all that uncommon to have a low normal A1C before the TPIAT. And because there's a lot of factors that affect how many islets, you get there, how well they survive, you can still have diabetes after the TPIAT, even if you have a good A1C going in. The reverse is less common. So if someone comes in and they have an A1C of 6.2, 6.3, which is not diabetes range, but is in the borderline pre-diabetes range, it becomes pretty unlikely that they're going to come off insulin after surgery. So on kind of the flip side, after surgery, we do sometimes see people who are on insulin therapy and have an A1C about 5.2 on insulin therapy. That could be a signal that there's room to back off on the insulin, but it depends on a lot of other things in terms of what we're seeing on meter monitoring or CGM monitoring and function of the islets when we do tests like mixed meal tolerance tests. So there's some other factors we consider there too.
Okay, just a couple more here. My son is nearly 3 years out from a Tpiat surgery. He had an episode of gastritis last week. Is that a condition more common in Tpiat's patients?
Yeah, we do think that it is something that people are going to be more at risk for. Again, just because of the changes in the motility of the intestines and sometimes the stress that the body is under, may be more likely to produce some extra stomach acid. So it is something that we're preventatively treating early on, and we do sometimes keep people on some long-term antacid medications to prevent some of those from happening.
Thank you. Another question is, are you able to give examples of the tube feeding products that are used post-op?
Can I get maybe perhaps a little bit more clarity? Are you wondering about like different types of formulas or
Maybe
That's what I would guess, Elissa, is formula. Yeah.
So most of the formulas that we're using are formulas that are called extensively hydrolyzed, so that the proteins are broken down into smaller chunks so that they're more easily digested. And we're using different types of fats that are, again, more easily digested. So we used to use in our hospital things like Peptamen Junior or Pediatric peptide, but we recently changed the formula options that we have available. So now we're using some of the Impact or Vital peptide formulas, again, where those protein chunks are broken down and can be more easily digested.
Thank you. Another question is, to make sure they understood, they're asking for just the transplanted islet cells only survive for up to 15 or so years after a Tpiat?
So sort of. The transplanted islets tend to have less function over time. So the islets may not be working as well 15 years after a TPIAT as compared to a year or two after a TPIAT. there are many patients who still have islet function 15 years after TPIT. There are not as many patients who are off insulin, but many patients who still have function 15 years after TPIT. So they certainly can keep functioning that long. It's just that they tend to do a little bit less over time. So you may be someone who's off insulin for 5 or 10 years even, but by year 15, you might be, using a little bit of insulin every day again.
Thank you. I know that we're answering a couple in the chat. Do you see another question that you'd like to look at, Dr. Bellin?
So there is a question. Sorry, I was trying to type some as I went along here too. There's a question about what is it called if you have a TPIT and then you're no longer on insulin, because that is actually a pretty tricky one. So what I personally like to do is call it diabetes in remission after an islet autotransplant. That terminology is also used in, say, like type 2 diabetes, where people have bariatric surgery and lose a bunch of weight. But it keeps diabetes on the radar. So number one, it kind of allows people to be able to get their supplies, because sometimes insurance companies, if you don't attach it to a diagnosis of diabetes, frankly, don't want to, cover things like meters and test strips. And then number two, it keeps it on the radar if you present to a hospital sick, you show up in your primary care clinic, that diabetes is something they need to be watching for.
Thank you. I think we've answered the other couple of questions, unless you see one on here. There were a couple of duplicates, but we can also recap these and send them out to all the participants as well. But I just want to know if you see another one that you'd like to answer.
Yes, I'm looking. I think a few people put them in the chat.
Yes.
But one of them is about islet graft failure. Why do you think there may be a reason for increased islet? I think that the reason that we see that attrition in islets at 10 to 15 years is probably just because the place where they're living is not a healthy, normal pancreas. So there probably is just a little bit more stress and pressure on them over time. And that's why we see that decline over time. Yeah, but I'm and I think Elissa as well, we're both very happy to be contacted by email or sending questions through NPF, and they can email us the questions. We're certainly happy to answer other questions as they come up.
Yes, thank you all for your time. And I want to just remind everybody I want to thank you both for joining us again tonight and for your support throughout all the sessions. But I want to remind everyone who might be interested, our last session will be of the series will be Tuesday, October 19th at 7 p.m. And it's what to know about life after Tpiat for the teenager. And we'll also include a patient perspectives. So I hope you all will be able to join us then. And just to reiterate, if you do have further questions, you're always welcome to submit those to info@pancreasfoundation.org. But thank you again for joining us.
Thank you.
For that,